My talk is going to be about exercise and health maintenance in cancer patients and providers. But it's not just about patients and providers. There are actually elements to this that apply to us all. It turns out that exercise and physical activity is good for us all. And how do we know about this? Let's see. So we learned a lot about this in longevity studies. So what is a longevity study? You look at populations of people who live long lives, and you see how their behaviors are and what they do. And where I first got interested in this was I've been practicing karate for most of my adult life. And when you do that, you actually learn about the people who developed the art. And it turns out Japanese karate pioneers were Okinawan men, a group of Okinawan men who lived in the late 19th century. And a recurring theme of these practitioners is they were living into their late 80s when the life expectancy of Okinawan men back then was about 48. So these are not just outliers. They were doing something right, because this is before antibiotics and vaccines and what would be considered, traditional medicine. So looking at these people and other societies where people live long, we've been able to identify some non-medical longevity practices. Regular physical activity can be exercise. It could be that you're a hardworking person. So a lot of the older previous times, people did farming work, fishing work. They were just physically active all day long. A nutrient-rich diet, low in processed food, sugar, and certain fats. We don't have that kind of diet all the time in the United States. It's something that we have to, actively seek out. Avoid smoking or passive tobacco exposure. I think we all know about that. I would say avoid vaping, avoid putting anything in your lungs that isn't fresh air or prescribed by a physician. Good sleep hygiene, getting adequate sleep. This allows you to be more refreshed during the day. It lets you work better. It is just good for you. And then active stress management. So we have very little control over the stressors that come into our life. They're going to happen. We have complete control over how we manage them. And so you want to learn stress management, whether it be meditation, yoga, or exercise, and there's a number of different ways to approach this. And the last three are kind of unique, and we don't talk about this enough, but social connections and being part of a community, particularly a nurturing community. This group of people here at the Roosevelt this weekend, nurturing community. Everybody's here with this common purpose. We're trying to help people fighting cancer. Having a sense of purpose and fulfillment, and then having a positive attitude. So this is my granddaughter, and I have no data to support this, but I think grandchildren help you live a longer life. But actually, what's that? Yeah, that's it. But I was thinking about the positive attitude and the sense of purpose and belonging to a community, and I think children have a way of bringing this out in us. It certainly does in me. I am so much more focused now on, I really want this world to be a better place for my grandchildren and my children and your grandchildren and children, even though I don't know them. But those are the sorts of things that have tremendous value. I can't write a prescription for that. It's not that sort of a thing. So what happens when you get cancer? All of those wonderful things we just talked about, take a blunt trauma right into it. First of all, there's existential concerns. No matter what the stage or type of cancer, when you get a cancer diagnosis, you are immediately wondering, am I going to survive this? My job upon giving this sort of news is to try to help that person understand the prognosis, help them with those questions, and then figure out the best way to manage the disease. So then fatigue, anxiety, and depression. So having cancer is emotionally exhausting. So there's fatigue from that superimposed on the fatigue that the treatment and the disease have. So you're always tired. And then the sleep disturbance, because you're lying awake at night worrying, or maybe you have a pain issue related to your cancer. So you're not sleeping well, you're tired all day, and you just kind of keep tumbling down a path of feeling worse and worse. And then the loss of autonomy. Your disease process, while it's being actively treated, is going to control your life. You have, medicines to take, appointments to make. You no longer have the autonomy that you once had. And then a lot of times cancer patients feel isolated. They feel like they're in a room full of people, but they're the one with cancer, because maybe they have lost their hair to chemotherapy, or maybe they're having to wear a mask because they're immunocompromised. They just don't feel as much a part of the community sometimes. And then chronic worry and stress, again, part of being a cancer patient, particularly early in the journey, and then financial burden. And I want to just take a minute to talk about financial burden because this is an advocacy meeting. So in the United States, about 550,000 families a year go bankrupt because of health-related expenses. Most of these are cancer patients. There are cancer patients who have to choose, can I live a little bit longer or maybe even be cured and leave my family, bankrupt? And there are people who choose to put their family first. I don't think we should have to do this. And I was thinking that when I was 9 years old, the United States had 2 men walk on the moon. Since that time, the number of countries that have put people on the moon is exactly 0. Nobody else has been able to do it but us. Since that time, every other first world country but the United States has some type of a healthcare system that covers everyone. So how is it all those guys can do that and we can't? Yet we can go to the moon. And I'm all about going to the moon. I love NASA. But I actually think taking care of our population with healthcare is even more important. So the consensus statement from the American Cancer Society is, research has shown that for most people, exercise is safe and helpful before, during, and after cancer treatment. It can help improve one's quality of life, level of energy, and sense of well-being. Physical activity may help a person cope with side effects of treatment and may decrease the risk of cancer recurrence or new cancers in the future. So this is something Troy touched on earlier. I'm going to expand upon it, but I'm going to get into more specifics. This is a very general statement. So we're going to talk about specifically how to help people, how to prescribe this, and then some of the science behind it. So physical activity should be individualized, planned, and adapted to patient specifics. It's precision medicine all over again. One size does not fit all. So this is just good old-fashioned healthcare where a provider is going to try to figure out what's best for his patient and then prescribe it. So you have to take into consideration age, comorbidities, and performance status. People get cancer from birth to, however old they get, and they have to have their care individualized. Disease and treatment specifics. If someone has metastatic disease and weight-bearing bones, there are certain things we do not want them to do, and there are certain interventions we do want to do to help make those bones stronger. Is someone recently post-op? So there's a lot of things to be considered. It's not static. It's not an aspirin a day for the rest of your life to prevent stroke and coronary events. It's something that's going to have to be modified continuously. And then what stage of the disease journey are they in? Has someone just been diagnosed? Are they going through chemotherapy? Or are they a 5-year survivor who may have some neuropathy from their past treatment? Or maybe they're perfectly healthy, but you still have to individualize your care for what they need. And then what were the patient's premorbid activities? So obviously, if you were not an exercising person before your cancer diagnosis, can you become an exercising person? You can, but it's going to require a different program. And a couple of things I think are interesting. Lance Armstrong won the Tour de France 7 times after being treated for metastatic testicular cancer that presented as brain mets and hemoptysis. He was given a 15% chance of living. He came back and he won the Tour de France 7 times. Part of the story that's really interesting is while he was getting platinum-based chemotherapy at the University of Indiana, he had a stationary bike in his room and he would work out every day. So world-class athlete, I'm not going to become a couch potato. I'm going to keep on keeping on. I mean, the Saints have a tight end right now who has been cured of Hodgkin's disease. So the person that goes into the illness has some unique needs. We try to work with them through it because after the illness, they're going to want to go back to being active again. So how is the physical activity program working? And tolerance and efficacy, as we do with any treatment. Is the patient tolerating it well? Are we achieving our goals? And if not, we're going to keep making modifications. And then lastly, what are the patient's long-term fitness goals? My long-term follow-up patients, I kind of put my internal medicine hat back on. I make sure they're doing all of the things we recommend for good health. But I also want to, look at how they're doing with their physical goals. I think we should all set goals. I used to coach the karate club at Nicholls State, and I would have every year people fill out brochure. These are my goals for my health this year, and these are my karate goals. And people are like, what do you mean your health goals? You know, college students. Well, what do you want to do? You want to lose weight? You want to gain weight? You want to join a gym? You know, just try to figure it out. And if you plant that seed early, when they get to be my age and health concerns are, you know, out there more frequently, you have a plan and you're able to take better care of yourself. So areas of reduced morbidity with physical activity, and we just touched on this, but I'm going to say it again because it's really important. The side effects of cancer treatment are reduced, and you're doing this as an adjunct. You're still using antiemetics. You're still using magic mouthwash. You're doing all of the other things we do, but when people are active, their side effects go down. Fatigue. Now, this is counterintuitive. Oh, I'm going to be less tired when I'm exercising. You are going to be less tired when you're exercising. It's going to do a lot of things to help you with fatigue. It tends to reduce anxiety and depression. It tends to help you sleep better. And then one of the other issues with going through cancer treatment is deconditioning. You're not as active. You feel a little more tired. You put on some weight. You're a little less happy. It's another one of those snowballs. So getting involved in a program of physical activity helps fight this. Metabolic syndrome is a big problem in the United States for people even without cancer. Exercise is a big part of that, and that would be diabetes, hypertension, dyslipidemia, those sorts of things. And then immune suppression. The immune system is actually benefited by exercise. So how do we know all this? Let's put our science hats on for a minute. So I did a literature search about this because I've been reading about it and I wanted to know more. And when you do a literature search, there's a tremendous amount of literature on this. It's huge. And I'm like, okay, well, I've only got a certain amount of time to give the talk. I can't talk about everything. But I found a review article in Cancer 2022 that looked at a whole bunch of publications, meta-analyses, systematic reviews, randomized control trials, case control studies. They did subset analyses from randomized trials. So they were able to take a tremendous amount of data to study this. And so multiple studies have reported reductions in the recurrence and mortality in breast, colorectal, and prostate cancer. If you look at the NCCN guidelines for all of these diseases, exercise is in the recommendations. And there's a significant variation in physical activity programs in the studies. So it's not something easily done. You can't really do a randomized controlled trial of exercise because you can't prescribe the exact same thing to one group of people, and you certainly can't randomize somebody to a sedentary arm. So we have to use a little more thoughtfulness in how we do the science. Now, one of the things I found, I'm not going to spend too much time on it, or what are the mechanisms of action as to, why does exercise work? Because there's got to be a reason for it. And, scientists are not going to be satisfied with just taking it without data. And there's a number of things in there. And if you have some time, it's worth reading this article and then maybe going through the bibliography and picking out some of the individual articles that support it. So what are the barriers? So in practice, only about 40% of cancer survivors and 7% of cancer patients in active treatment are getting adequate exercise. So we know it works. We've got unequivocal data showing that it works. Why isn't everyone doing it? Well, there's a lot of barriers, disease and treatment-related symptoms. So there are people who, in their current state of disease, can't do certain things. So you have to modify the program to what they can do. And then there's a fear of exacerbation of injury. People do have real concerns about what might happen. Their attitude toward illness, their interest in physical activity, and their coping strategies. People who naturally are exercisers are going to want to continue to do it because when you take that away from them, they suddenly aren't very happy. I know Troy can tell you when my shoulder was hurt and I wasn't able to do karate and I couldn't do my yoga, I was an unhappy dude, which is why I was so happy they were able to fix me. And then social and family support, access to facilities and instruction. I mean, there are a lot of potential barriers. Not everyone can afford a gym. If you can and you can get a personal trainer who really has experience with this, it's that much better for you. Or you see a physical therapist who can set you on the way. And then just a lack of awareness of the benefits. It's not something that's going to be in the plenary session at ASCO. It's important, but it's not going to be up there with the big, sexy clinical trials that are earth-shattering as far as improving survival. So lack of awareness, we're talking about it here at CAGLA. So what are the suggested amounts of exercise? This is the American College of Sports Medicine and the American Cancer Society. So try to get at least 150 to 300 minutes of exercise at moderate intensity every week. Start at about 30 minutes a day, 5 days a week, and then adjust according to tolerance and conditioning. The important thing is where you start. I always tell people do something well within your capability. Do not go out the first day, push yourself super hard, because then you're exhausted and you're going, I'm done. If anything, be a little conservative in your start. If it's not 30 minutes, that's okay. If it's 20 minutes, that's fine. Do what you can do, keep track, see how you feel the next day, adjust accordingly. So aim for 2 to 3 strength training sessions a week focused on the major muscle groups. Strength training is extremely important. If you're the healthiest person in the world, you want to age more healthily, you want to add strength training. And then stretch your major muscle groups 2 times a week. I think stretching is probably something you should do a lot more than that. And part of it is because I come from a martial arts background and I do yoga 5 days a week. So I really think stretching is important. It helps you be more flexible. It helps with your balance. It reduces your risk of falls as you get older. And it just keeps your muscles more healthy. So yoga in oncology care. So everyone loves to talk about yoga as something to help us. It is a marvelous practice. So it's a 5,000-year-old mind-body practice of Indian origin that incorporates movement, stretching, controlled breathing, meditation, and relaxation. There are a number of different forms of yoga, and each studio has its own unique way of approaching it. Each instructor may do their own thing. So there's a lot of different types of yoga. You want to find the people that work for you. Speaking of communities, my little yoga group, those are just my people. We kind of understand each other. We see each other out, and it's just a neat little community. So the clinical practice guidelines support using yoga to manage fatigue, nausea, stress, depression, sleep disturbances, cognitive dysfunction, and pain. It works for a lot of things. A typical practice includes some cardio, strength training, bone health, stretching, balance, and breathing. So I like to do Baptiste type flow yoga, something called Journey into Power. And we do what's called, just all comers, there's no judgment. No one has to, you don't have to do everything. You do it at your own pace. There's just an infinite opportunity to individualize the practice. So I'll give you an example is 2 of my yoga friends. One is a professional musician and dancer. And sometimes if she has a late gig, she'll spend about half the time in Savasana and the other half in Happy Baby. If it's not after a late gig, she looks like an Olympic gymnast going through her yoga practice. She does the practice that works for her that day. And there's another friend who's a former college football player who had just recovered from arthroscopic surgery in his knee. And he had to modify his yoga practice in order to meet his specific needs. And I think it's kind of cool to see a guy who's 6'4", 220 doing yoga. Because, football and yoga, you don't think they go together. They absolutely do go together. So here are our conclusions. Physical activity is a safe and effective adjunctive component of a holistic cancer care program with a broad spectrum of benefits. You need to purposefully evaluate your patients and prescribe an individualized physical activity program. This is real art of medicine stuff. There's no app. You can't get it off AI. You sit with your patient. You know them as a clinician. You know them as a person. You talk about it. You prescribe something you think will work for them, and then you make adjustments. And then you monitor and adjust the program according to tolerance and efficacy. And then as providers, we got to practice what we preach. One of the themes of our meeting is taking care of the caregivers. And, we can tell people what to do, but if we're not doing it, are we really being sincere? And are we really being good providers if we don't take care of ourselves? So, namaste. And I can't help it. She's just a cute kid, and she's wonderful. And, when I get texts with pictures and videos from my daughter, whatever I'm doing, I stop and watch it. So, because it makes me feel good and help me live longer. So if y'all want to we can come up and take questions.
One of the things you talk about barrier to entry, right? Like, we've won some pretty major legislation in physical therapy. In some insurance companies, there are rules, and even in Medicare, there are limitations. It's based on patients' improvement. They have to meet goals. They have to succeed, right? In cancer, they don't. Not only if your patients have insurance, health insurance, is it you can come to your physical therapy provider and not, in cases where it may be too expensive to be able to pay for a personal trainer, right? Or join a gym or join a group. Yes, those resources are available. I do take insurance, so I'm very well aware of some of the legislation that we've won in being able to continue patients in physical therapy without them having to even meet an outcome requirement. But a lot of the things we do when it comes to finances too is, meet everybody where they are. One, you got right. It's consistently that, and that's okay. There's always a way, right? Like I told you, we have an app that I can put them in our app and give them, video coaching, right? If they do work in an environment, I mean, one of the biggest ease of entry is that if a patient has a form of activity or exercise that they have enjoyed, right? It doesn't matter that they were doing it before they got cancer, haven't done it in 10 years. But you first want to find out, like, what is the patient's favorite thing, right? Yes. Or what's a friend or family member do already that they could bring this person along with them, right? So we give a lot of great questions and figure that stuff out first, right? We don't jump into, I need you to do this, right? Like, it's not a 3 reps of 10 kind of thing. It's a lifestyle. So we focus it on, and then we can always torque and twist things, like patients with yoga, right? We can modify something and that there's some very specific thing we need to work on. We can give that as a warm up or a cool down, right? And one of the most important things to discuss about the why and the how it's effective is the body remodels in the musculoskeletal system every 10 to 16 months in the basic ways we stress and strain it. So the simplicity that we all need to understand as clinicians. If a patient does bicep curls and they do it every day, if they add weight and add load, the muscle is going to get thicker and stronger. And over the next year, it's going to be able to handle a lot more force. If they add a lot of repetition and continue to add repetition, the body's going to adjust. It's going to acclimate, right? If they do not do any of those things, what's going to happen? The body's going to be less capable, right? And then it's not as strong, not as functional, doesn't have the endurance. So we lose. So the point is that if as we age, we don't do X, Y, and Z. Women, osteoporosis, strength training. What do we miss in women? We miss high load activity on female because females aren't used to working out that way. Funny thing, it's the most important thing for most of them because it's the one thing they never do, right? So it's the kind of models of understanding the person. So many different ways we can add to that, but I hope that answers your question. Oh, I'm sorry. Okay. Yeah.
So when you're working with a patient through insurance versus
Private.
private pay,
Yeah.
I've shared with you in the past that we're hand in hand with many physical therapists and look for a lot more than insurance.
Yeah.
And a lot of what I like of referring to the private pay is that there's much more flexibility what they can do with their patients. There's a lot more on the table, hands-on, one-on-one time when it's outside the insurance model. There's been, and these are people who have had to do that for a long time. So now that we have these legislations that have been pushed through that have really opened it up for you in the oncology world, how much time is one-on-one versus pumping through like what we see in facilities, medical models that use insurance? When you're working with insurance versus when you're not,
In our program, it's not much different, to be honest. But we have enough clinicians to be able to provide hands-on care. There is a lot of misunderstandings too. I mean, first you got different levels of clinician and what they're good at. And that's in any form, right? So you have some physical therapists that are great manual therapy skilled physical therapists and some that aren't as much and they're more exercise based. And so you do have to find the clinician that's right for you in that scenario. But even in the insurance model, I know that some people rush people through. We get to spend one-on-one time with all of our patients, and we don't have any limitation to that. And we also have physical therapy assistants that assist us as well. So if a patient needs more of a certain massage technique, but realistically, if you can have a 30-minute session with a patient, there's so much you can do. And now we've got tools now that honestly are way beyond the time of spending an hour doing manual work with your patient. If you're an expert in therapeutic dry needling, you can change the way a muscle adapts to movement instantly, right? Shockwave therapy, we can remove pain and dysfunction in a joint immediately. And so then we can get off of some of the manual therapy component and do more of the functional medicine and going into the new functional movement pattern the patient now has, and the more important thing of strength and conditioning inside that new range or that new functional capability, right? So the circumstances are always unique, but even in the private practice insurance model world, I do manual therapy with every patient I see. It's not a limitation. And I know, I have some new grads that would take an hour to get out of a patient, what some of the advanced clinicians might do in 5 to 10 minutes. That's a shame, right? But no, you don't have to pay privately and be able to afford private therapy to get good physical therapy. You might need to, though, choose which physical therapy group you go with in the private, pay and insurance sector, because everything doesn't look just like the other. Mm-hmm. Mm-hmm. Mm-hmm.
They don't need as much.
Yep. Yeah. So, yeah.
I will say, because we work so closely with our physical therapists, that for patients with Medicaid and or free care, they're still entitled to physical therapy. And when you send them to a facility like University Medical Center down the street, our patients who are living with cancer are also getting physical therapy. They're getting manipulation. We have 6 physical therapists who are certified in dry needling and pressure point needling. So really taking that into consideration. Also, part of the basis of functional medicine is also empowerment of the patient to be functional. So it can't just be one medicine fix it all. I get this a lot because I do a lot of pain management. And so we have to empower our patients to really take ownership that they're not going to get 60 minutes directly with the physical therapist or with the palliative care doctor or somebody who's going to walk them through every piece of this, that we have to empower them of how to do this on their own as well. So even Troy treated me as well for 3 cervical herniations that I have, dry needled me as well. And half the time that I was there, I was doing those exercises, which I still do to this day, right? And so, yeah. And I do also want to say, Dr. Ellis made an excellent point, right? That if we don't practice what we're preaching, our patients are never going to listen to us. And how disingenuous are we if we're not taking care of ourselves and yet we're asking our patients to take care of themselves? And if we're not open to trying things like dry needling and yet we're asking our patients to try that, right? So I think we need to practice a different mentality in medicine altogether if we're going to truly do supportive care, which has been proven over and over again works for people.
Great questions.
Yeah.
Hi, I got some questions over here. So my first is, although Dr. Calhoun, it sounds like you guys have really closed the gap in terms of making sure that your patients are receiving palliative care, but I think more broadly, there's certainly an unmet need for linking patients with PA, with PCE. Do you guys feel, is there space or room for any type of EMR, IT integration to be able to screen and identify patients that are suitable for those types of referrals, and then automating consultations and referrals to ensure that we're reaching the most patients that we can?
Absolutely. And so I'm presenting at the Center to Advance Palliative Care's National Conference in Philly in September, and we talk about triggers. So what you're saying is triggers, triggered consults in the EMR. There is absolutely a role for that. There's a wealth of data that supports that. The challenge I have is we are busy enough. We have enough patients. It's hard for us because of our bandwidth. Even with 4 physicians, 3 APPs, and 2 social workers, our list last week was in the 50s on our inpatient census. It's really challenging to take care of 50 patients every day. And so triggers work for some groups where there's low consultation. And I do virtual office hours for CAPC. And so I show people how to build their palliative care programs. So for those who have low consult volumes, I tell them use triggers and start small because that will grow. But for those programs that are already having trouble with sustaining their volumes and providing quality of care, triggers don't help. But certainly the first and most easy trigger is metastatic cancer.
Well, and I think that also speaks to, you brought up the bandwidth and funding is two major constraints. I think there's a lot of institutions that certainly feel the same way. I came from Vanderbilt before this position that I'm in now, and that was certainly something we felt there. But I was curious that in your space, do y'all get any cost effectiveness work? That was something that we tried to incorporate in order to go back to the administration and say, look at the return on investment. Not only are the patients having better outcomes, less hospitalizations, survival approvals, but that is in turn saving money in this way, shape, or form. So we had to invest in us to try to make sure that we're able to build more capacity.
Yeah. My 10-year career has been building palliative care. So all I do is interface with C-suite leaders, and they're challenging at times, to say the least. I will say the probably best C-suite leader I've ever worked with, has been through LCMC, 2 of them, our current one and the one who started our program. And the cost savings benefit of palliative care is tremendous. However, most C-suites are not looking at cost savings. They're looking at generation of revenue. So the way that I've gone about that is to pair up with those service lines that are generating a lot of revenue within the system to have them advocate for my integration or for my team's integration rather than me having to go as the palliative care doctor. For instance, at East Jefferson, we were getting slogged on our pro forma. They kept cutting it. The C-suite just kept cutting it. And so I asked our heart transplant and our LVAD individuals and our cancer service lines to advocate on my behalf. And now we've increased that. We actually increased by 4 times the support that they were trying to give us. We've increased that through that advocacy. So yes, length of stay readmission rate was data we were using before to advocate for supportive care. It doesn't work in this day and age where most healthcare systems want a 2 to 5% profit margin, which is crazy to think about in healthcare. And I think Dr. Ellis said it beautifully that, we've sent people to the moon and yet we can't figure out single payer in this country, right? No matter what your political beliefs are, we're all taking care of patients, human beings, not illegals, not whomever. We are taking care of human beings, and we haven't been able to figure this out. And so oftentimes I have to talk about cost neutralization. So I don't make the hospital money. I balance off the costs of my service line, and I save multiples, millions of dollars through readmissions, quality metrics, all of that. I monitor it. I don't have I recognize that LCMC Health, we don't have a well-functioning informatics system. And so I keep a lot of internal data to show them and relate it to the national metrics.
Thank you so much. Just one last question for Dr. Marquardt, and I will stop, I promise. So what I'm doing now is focus more on lung cancer. So we have a older sort of patient population. And of course, there's some considerations with physical activity, of course, safe oxygen exchange. But also there is a lot of loneliness and isolation, as Dr. Ellis pointed out, in this population. So could you speak to how integrating with physical activity could actually sort of help improve some of those areas as well?
Absolutely. The mental health side, my wife's a psychologist. And so the mental health side of this is, you look at quality of life, someone's mental health is not just effective for themselves, but it changes the world around them, right? How they relate and communicate with their friends and family. And so I think understanding the mental health needs and getting family and friends involved, that's always a wonderful part of what we do. And it's the purpose and intention of why we're helping these patients, right? Is so that they can do that. So I love doing things in that nature, right? In the situation of a spouse or a child, being able to do something with their loved one. I thought of you with talking about karate or yoga, right? I mean, just something as simple as, what if you got to do that with, a friend or a loved one? You got people too that in some of these families and friends, their support groups, they want to know what they can do for people. They ask, is there anything I can do for you? And, usually it's no, or bring a meal, right? What if it was come in and exercise, listen to some music, dance? I mean, I can't tell you how many of my patients, the simple form of physical therapy exercise they get is to dance with their spouse, right? Something so simple, right, is so wonderful. And it's on many different levels. Another thing that I feel like really needs to happen, and we talk about points of entry. I'm in 3 health clubs on the North Shore, and when a member comes into the health club to join membership, they get offered to consult with a physical therapist before setting up the program, right? Because they've got comorbidities and issues in their life and past related injuries, and they don't know where to start, right? And in most of those cases, they're not coming to physical therapy to stay in physical therapy. Some of those cases have issues that they need to deal with, because that's why they can't exercise and why exercise has been unsuccessful. But in most of the cases, it's a simple understanding of where to start, how to start. And one of the things about the care team that is kind of tough and frustrating for me, right? And say that case that I saw a year and a half after he's been dealing with it, is what if that team of providers immediately in the program of care says, okay, would you like to consult with a physical therapist to better understand your safe ways of movement and exercise, to discuss your specific needs, goals, right? What if there was just a simple, in what we could do in one consultation in the beginning of care, establish a relationship, trust, have someone with the knowledge to answer all these exercise questions, because we have objective ways to evaluate and set up a plan of care, right? That they now have the resources they need for when they need it, for as the conditions might change, right? I mean, the simplicity of, okay, so this is my person who does this is my person who does that, oh, this is my person who helps me with this entity, right? I mean, so I think that there are immediate things that can happen, but the more important thing is, we're all a team, but we kind of all need to be brought to the forefront of participating in the team sooner. And ideas to do that and trigger that and create opportunities for that, even if it's just a consultation, I think is clearly necessary relative to the data we're showing you today. You're welcome.
I'm going to just say one thing that I learned from both of y'all's talk is I'm going to actually start to deliberately ask our patients, what is their individualized exercise plan? Because it's so critically important. How much of this do we actually do for best supportive care practices? Do we have our own individualized plan in it? For anyone who's ever read the book Atomic Habits, has anyone read that book? Yeah. And in that book, it says it takes 10 days to build a habit. And the best success of building a habit is if you do it every day at the same time. So when I wake up every morning, because I have 3 kids and they are a lot to manage, especially the number one, who's a teenager now, I wake up, I do my meditation, and I do my strength training exercises right off the bat, because honestly, at the end of the day, it's not going to happen because everyone else's needs are going to trump my own. And so how do we encourage also our patients to build those habits, even though they're going through a really rough time with their disease processes? If we build more normalization of routine, I've seen it, and I'm sure Dr. Ellis, you've seen it, and Troy, you've probably seen it, that they do a lot better.
All righty. Anybody else? Yes.
One of the things that I see with, I work in outpatient infusion at East Jefferson, and a lot of my patients have ports,
Yeah.
and especially kind of cycle one day, one patients, and maybe they have, been more active in the past, but they'll ask me about, what can I do with the support in place? And I'm definitely, I'm like, I don't know that boxing is a good, exercise.
Yeah.
But honestly, and I've only been doing this for 2 years and a few months oncology. But what are those limitations really with, with having a course?
So the main thing with a portacath is you want to avoid any type of trauma. So I wouldn't, you could do a martial art, but you wouldn't do active sparring, or you'd work with someone who understands that. You sometimes have scar tissue and discomfort. Most of the time, people with portacaths are pretty functional. But anytime you have anything like that, trauma to the area would be pretty, devastating.
Speak specific to that. Very common for me. I mean, I get that question, right? And it's very interesting. So what do we limit that patient in? Say boxing, right? What if the patient that asked you that question is someone that their form of exercise is going to their boxing class, and that's their community, that's their friends, that's the people they love, right? Okay, so perfect example of that is I'm not telling them no boxing. Okay, what I'm telling them then is tell me about your boxing class. What are you guys doing in the boxing class, right? And they tell me, right? And I say, okay, well, with this port, right, depending on when the port was installed and what kind of issues we have, and I mean, there's a lot of questions I have to understand, right? But that patient might not do maximal exertion push-ups with the class, right? And I may have modified that and gave them a beautiful new form of exercise on something that, by the way, is bothering them because of the ports in and their postures like that. So I may be giving them a different form of exercise. And so class does this, you're doing this, right? Right? Heavy bag. Okay, you might not be punching the heavy bag right now. But what you're going to do, you're going to shadow box. So while they're doing this, you're doing this, right? So a lot of these things where you think, because the first inclination is no, you can't do, that's dangerous, danger. And that's the patient, and then the healthcare provider and doctors and nurses saying the same. And it's like, guys, oh, we don't have to be scared. We don't have to be afraid. We've seen enough of the good and the bad and what can happen, and we need to keep the people in the programs, right? So if that's the program of choice, just talk to me. Tell me what it is. What are you doing? I'll modify and scale it to fit you perfectly. You'll be comfortable. You'll be pain-free. You'll feel better when you leave the class, right? And you're going to be with your friends, and you're doing it, So I want to remove that fear. That's the first priority of what that patient needs when they're asking that question with a port. Is it's okay. You don't have to be afraid. We'll figure it out, right? Does that help? Yeah.
It does. I can try to encourage, I am, like, if they're obviously not a runner or,
Right.
I'm like, well, now it's not your marathon start training, but walking is good, riding a bike, or, the gentle swimming maybe, or, stuff like that. Obviously, when the incision's healed.
Yeah.
But, I do kind of encourage, I guess, more gentle, less contact type sports.
Sure.
But,
Consult their physical therapist. The greatest thing you can do in that scenario is let them go speak to the person who can modify and scale everything, that can assess them and evaluate. I've got cases where they are tighter and they would pull on the port at a certain movement. So guess what? All their exercises and movements are limited to a different range to protect them from ever feeling that, right? So my advice to you in that scenario is this would be a great time to consult with your physical therapist and go through a program and let them figure out a way for you to scale and modify and fit a program that's specific to your needs, because that's really the answer. Yep. You're welcome.
I love how we all sort of said, the mind goes to a place of no first and of negativity. I have a lot of patients. I work in inner city New Orleans, and in the summertime, it's really hot. And it's really not safe in some communities, right? Like you cannot walk around neighborhoods. I had one patient with interstitial lung disease due to sarcoidosis. She's like, I can't do this. She's on oxygen. I said, every time you go to Walmart, because she would go to Walmart and pick up her groceries, I want you to stay out of the electric wheelchair for at least the first 15 minutes of your sort of walk around the aisles. And that's what she started doing. And we set small goals every time. She was super anxious on like a lot of medications. And we just had to go through those small goals and establishing a routine. She just recently died from COVID, but at least we got her through 3 to 4 years of doing some of the things. And we slowly got her to start facing society again, going back to church, those types of things that build community. You're sitting with patients for so long when they're in infusion, talking to them about their support sources, their community, because living in this day and age when you're healthy and by yourself is hard enough. For those who are living with cancer, it's even more difficult. And it's really, really challenging, if not impossible, to do this alone. So I encourage patients, build a support around you. And many people are the sort of, Beyonce has a song called Me, Myself, and I. They're of that mentality. I can do this by myself. I'm going to do this by myself. It's just me, myself, and I. No, 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 no. We got to reframe that. We got to bring it back to community. And how do you build that? And that's a perfect opportunity when they're sitting in the infusion chair with you. I also tell people, when I was on my fitness journey, I started really small, 2,000 steps a day. And then I ramped it up to 5,000 steps a day. And now I'm at 10,000 steps a day, right? So slow, achievable goals. And do that for yourself too, so you know how to guide other people through it.
It seems like, a lot of people get stuck in this exercise bubble, right? But what y'all like talking about, especially like the boxing, right? And, the Walmart, then going to the church, it's like, it's not exercise, it's getting people engaged in movement that's meaningful to them. And that goes back to what you're saying, the meaning and purpose. Exercise and activity, it's a communal bridge, and it does, so much of that is meaningful for a person, aside from their sense of meaning and purpose in life, or all of their consideration or whatever.
I'm not an extroverted person. I am not an extroverted. I'm what they call an extroverted introvert. I don't thrive and build energy off of meeting large groups of people. I do have a lot of friends though, and then I know when to take breaks from them, because I recognize the value of having friends and how good it is for someone like me who's more introverted to get out there and do things, build that community. And we have to do that for our patients as well, even those who are introverted, just building community. And there's ways to do exercise and be functional through that. Thank you all.
Thank you.